Hello, my name is Margaret Solomons. I'm a community multiple sclerosis specialist nurse working in Northwest London. For the masterclass, I thought I would have a look at the review and reform of the community multiple sclerosis service. This is mainly because there was a real need for change anyway. Mainly before any issues with the past year. The MS service has been under resourced for many years, only one full-time MS nurse. 1 day of admin support's only recently been given. Large gaps and increasing gaps in therapy support for patients with multiple sclerosis. Succession planning has been highlighted, however, has not been addressed, and delayed progress in any quality initiatives that have been tried to instigate any quality initiatives. There's been big barriers and ongoing barriers to direct discussions with decision makers, which has always been a bit problematic. So actually doing this project was a good opportunity and good support for me to look at all these aspects. For the present service, the caseload actually has about 200 patients with MS at this time. That actually fluctuates quite a lot, but there is an estimated 400 in the community. Mainly patients are in the progressive stages of MS when they're on the community list, and that's because a lot of relapsing remitting patients already under neurology review yearly, some on disease modifying therapies and others are investigations, whereas with progressive patients, some aren't under a neurologist at all, they've been discharged or they don't want to be seen, but they have a tremendous amount of issues which still need to be addressed. Although we're lucky and we've got some medications now, not all patients are actually eligible for any treatments yet. There's about 40%, 30 to 40% of the patients are in advancing stages of MS from those progressive patients. So it's usually quite a lot of work and usually complex issues crop up. In order for the service to meet standards of practice and guidelines, obviously I have to link in with community and hospital teams, both MS and other specialists, as well as general services. In particular, it's really important that I maintain good links with neurologists and GPs, especially for medication reviews and complex case discussions. Following redeployment after this past year, I returned to work to find lots of issues had cropped up and patients were unfortunately feeling the brunt of the lack of support in the community. The first lockdown, it was very obvious that there was inequity between the community specialist services. There wasn't actually any support at all for the clinical cover, that is, for the community neuro services and MS service. The patients in the service, the needs weren't being taken into account. And neither with service needs. There was no allocated time to adapt to virtual working or write new SOPs, and the adverse impact was seen both with patients and the service itself. Things were really getting very out of control when there was no cover. So concerns were raised, and on the second lockdown, 1 day a week was allowed for urgent MS work, and obviously the time was extremely limited for any MS queries. Patients were found, on each visit, patients were found to have increasing disabilities. Appointment times had increased in length and also depth, and the number of appointments required had increased. There was always also increased referrals required for most of the cases. Um, Untreated depression was found, infections, bladder and bowel problems, even missed red flags. There was limited, very limited therapy input, and GP support was really hard to obtain. Just even getting through in a float phone was often a big problem for patients. And anyone who was known to the prescribing centres, although everyone, all the services were having a lot of challenges, and patients understood that, they were in a position that they couldn't always get access to even prescribing centres for many days. And there, of course, there was still no full-time community MS support, which would normally be there. So the backfall that patients would normally access help with wasn't there any longer. So concerns again were raised to the managers, and I felt as though there was a complete service review required. Obviously, we need to look at patient safety in the first instance, making sure that the service was fit to meet patients' needs at this time, especially post-pandemic, and ensure really that the national standards and guidelines are met. Looking at all of the different reevaluations of quality services, making sure that learning from the severe disruption, highlighting the patient's experience to decision makers, and demonstrating the value of the service, I felt was really important. It's been really, in particular, the costs and the time involved in trying to rectify problems that have occurred during the pandemic period when no one was available to support patients, or very limited support was for them. It's actually resources needed to regain a pre-lockdown baseline has been tremendous. Really, I felt as well that one of the important things would be to improve the collaboration and engagement with all the stakeholders to find out really what was needed, and patients being integral at developing new pathways and protocols tailored for their needs. So on resuming the multiple sclerosis role and resuming home visits, the very first patient seen was someone who had a secondary progressive MS, but advanced in their condition during the lockdown period. He wasn't eligible for disease modifying therapy, and his family were really struggling to cope. Although he did require therapy support, it wasn't, neurotherapy in the community wasn't available. Really, he was struggling, floundering, trying to find out if he could get any access to further help to get him back to the stage that he was before, because he had gone from working to not being able to work, from being able to transfer to being completely immobile. And he had a high anxiety and depression score, and was even talking about end of life care. Everything he was doing wasn't coordinated, and there was no collective goals or agreed care plan in place. A lot of work was required, and this is still ongoing. Lots of liaison with all the different services and coordination across organisations as well as disciplines. Although a lot has been put in place to support this patient, more is still required, just to get him to a safe and effective way of managing at home and feel supported again. Now, this actually led me on to looking at a little bit more depth with the patients who have been seen on the service, what their experiences were like without the MS service, and what it was like on resuming the MS service, and having further support again. And now the patients and the carers are just have a wee snapshot here of what they would experience before. And really there was a lot of negativity going on. Communication was a big issue for a lot of patients as well as the carers. They didn't know what was happening, and from a point of view of someone being redeployed, I wasn't allowed to intervene in the first lockdown. Although in the second lockdown, I was allowed to contact only urgent cases. But during the time that I was involved with patients, patients did feel as though they benefited, and so did carers. Likewise, staff, colleagues in the community were saying similar things. It was really quite intense on returning to work from a redeployed state to the post-lockdown findings. So I thought it would be wiser to actually look at everything methodically, look at each issue in turn and try and evidence what was going on before putting actions in place and making changes. I thought that this was the best and the clearest way in order to have discussions as well with managers so they could understand the thought processes and the rationale behind requests for either more resources or for changes within the service or links with other services. Looking at the actual service itself to reinstate and reform the community service, I also used a similar kind of process where I would look at the issues, making sure patients and carers were engaged, as well as colleagues, looking at auditing small sample groups at first for a little trial period to look at what was going on. Actually looking at the HES data is important, and that's actually still in the process of being reviewed, but also re-stratifying the MS caseload again. Really, the action required following these initial stages was to really find out more about what was going on with all the stakeholders, and in particular, really involving patients not just on the caseload, but in the wider community. Therefore, working with the MS Society to actually formulate a questionnaire, both for them and for the MS service, I felt was really important. So this is in the process of being sent out. We have involved, in particular, I have involved patients who are already on the caseload, who I felt would actually benefit from improving their confidence a little bit, because a lot of patients have lost their confidence over the lockdown period. So I've been involving them with formulating some of the questions and actually just reviewing how effective the questionnaire is and if they understand it before sending it out to other patients. And I think they've actually quite appreciated feeling that they're doing something useful and supportive for their MS service. So that's been an advantage, which is, been really helpful for everyone, as including myself. There are going to be changes made, and I am going to use the audit results from the questionnaire as well as feedback from other colleagues to implement changes. But most of all, I'm very passionate about making sure that the organisation managers and financial and stakeholders are all completely aware of the trauma that patients have had in the first instance, and how we can improve the situation for service provision for these patients. And really, I would like them to actually highlight the service and report findings to decision makers in the ICS. And the main aim is for a robust MS service for the future. in order to actually start gathering information, unfortunately, the IT systems don't provide a function to gather information that I feel is valuable in showing what is done in the service and how patients respond. Yes, we do have some ways of gathering information, but mainly just number of visits, very limited use really. Um, Therefore, a lot of the work that has to be done for auditing has to be done manually. Um, so I started off with a very small sample group, 10 patients. I mean, this is just a snapshot of 10 individual patients randomly chosen over a 16-day period. And just to show that actually the number of contacts for each of these patients, instead of being one or two visits or telephone calls, video consultations, it's increased dramatically. Also, the number of liaison required between services and organisations has increased, and these figures have actually, for these particular patients, are still ongoing for some of them. The referrals have also increased the number of referrals required. I wouldn't normally have to do quite as many referrals, especially for some of the patients here, because you would usually keep on top of it, and each visit would be issues would be addressed each time. So they've been gathering up and waiting for my return, it seems. I did ask, just took a quick poll regarding the questionnaire to find out if any of these patients would be interested in carrying out the questionnaire, and all of them were more than happy to do so. So that was quite encouraging. But even just from the work I've done so far and reviewing what I have done so far, there's lots of things which I can actually already start to implement. The patients are being involved more in what is going on with the MS service. I am trying to work even more in partnership with MS Society, and although pre-pandemic we had plans to do a lot of work together and training for patients and carers, it's changed its focus a little bit for obvious reasons, and we felt as though the post-pandemic feedback would be really, really valuable. So this has all been the process of going forward. One thing I do want to do is restart. It will be a virtual patient support group initially, and carer support group. But as time goes by, we hope things settle. As far as the service goes, continue to look at auditing things like reported outcomes for patients, looking for evidence that the care is being effective, getting patient feedback, aiming to increase the clinical and administrative resources, I think is really a priority. I have tried to engage the organisation to allow link nurses, but that hasn't actually been moved forward yet. I want to prepare a business case specifically to look at succession planning, because I do feel it's so important to have further clinical support within the role, so that patients are not left without any cover at all, if anything, if I am not available. I really want to upskill the community teams, and they're actually quite on board with this at the moment. So I am looking at putting in place some training jointly with the therapists as well as the district nurses for the service development and to enhance my professional development. I'm actually about to start some leadership training, and hope that that helps to guide me further to be able to engage more with managers and stakeholders, because I think that's imperative, and to actually get through to decision makers to actually see the value of a really good community MS service, so that patients can be seen closer to home. So in summary of looking at the MS service development, there are a lot of challenges, as in most services coming back from redeployment. But it is a good opportunity, and really want to look at improving patients' ability to self-manage when there's no support available. Although there is intense work in the next months to come, I think it will be really worthwhile, and really trying to find good ways of engaging with patients and other stakeholders is really important. Actually, the patient's safety and welfare is obviously paramount, and looking for new models to learn from patients' experience, I think, is one of the best ways to actually shape what's going on. I will continue to look at each issue that crops up and try and use clear processes and putting development plans in place, trying to keep up with monitoring and data collection is obviously very important, especially for decision makers, so that they can see the rationale and the benefits of actually implementing good changes which are effective for patients, and not just looking at numbers, but actually looking at the quality of what's happening and improved quality of life for the patients. Especially when patients are in a more progressive stage, I think that's really important. It is a live project, so ongoing, and really important that we do shape and reform the MS service for the local population. But the aim is for the patients to safely self-manage, and really making sure that the decision makers have information at their fingertips before they actually make decisions about services when they're reviewing resources. But finally, really the aim is to improve the service and prevent future service disruption, because I don't want to put patients in a similar position that they were in last year. So in conclusion, really listening to the patients' voices and engaging them directly in planning the service for future service provision, it can be more focused to support their unique and challenging needs. Working collaboratively with other organisations in health and social care, as well as voluntary and charity sectors, it can actually be a better use of the resources, and I think everyone recognises that. So hopefully it will be a more effective and efficient way to work. But financially and emotional costs for patients with MS and their carers can be reduced if the service they require and highly value can be protected for future challenges. So it's a lot of work in progress, and I certainly do hope that it is the results are positive. But I do thank not only the MS Academy, but also colleagues in the community who have been so supportive in trying to help through the COVID and redeployment period for not only myself, but for patients with MS. But thank you very much for listening.